webcast orientation to migrant health. This training webcast is brought to you by the National Center for Farm Worker Health. Important webcast reminders. This webcast will last approximately 1 hour. It has been pre-recorded for your convenience. After the webcast, please send questions to the presenter via email. This training is provided by myself, Cristina Brito Tijerina, the Learning Services Manager here at the National Center for Farm Worker Health. About the National Center for Farm Worker Health, we are a national nonprofit organization dedicated to improving the health status of farm worker families through provision of innovative training, technical assistance, and information services. For more information about NCFH, please visit us at www.ncfh.org. This training is made possible through grant number 430C509737 from the Bureau of Primary Health Care, Health Resources and Services Administration, and the U.S. Department of Health and Human Services. So our learning objectives for today, we will discuss the migrant health movement. We will identify farm worker demographics and discuss how the demographics and culture of the population impact healthcare access and delivery. Also, we will describe 2 services included in the migrant health program. Our course outline will be, this training session includes historical timeline, demographics of the farm worker population, an overview of living and working conditions, exposure to environmental and occupational hazards, health status and barriers to health care services, and migrant health services. Core competencies include, we will explore or inquire about migrant seasonal farm worker cultural beliefs, values, working and living conditions. Also, we'll discuss respect and honor of differences and seek to understand patients with unique circumstances and needs. Program requirements. There are 19 key health center program requirements divided into 4 categories: need, services, management and finance, and also governance. Acronyms. The following acronyms are used throughout this presentation. BPHC, which is a Bureau of Primary Health Care, CHC, which is Community Health Center, and MHC, Community and Migrant Health Center, DOL, Department of Labor, FW, Farm Worker, H2A, Agricultural Guest Worker Program, MHC, Migrant Health Center, MSFW, Migrant and Seasonal Farm Worker, OMSP, Office of Minority and Special Populations, OSHA, OSHA, Occupational Safety and Health Administration, PHS, Public Health Service Act, UDS, Uniform Data System. 330 is the section of the PHS Act that authorized funding for community health centers, and also 330G, section of the PHS Act that authorized funding for migrant health centers. These are commonly used acronyms in the migrant health field. So, historical timeline. This coming section will provide you with some history on migrant farm workers in the U.S. The presence of migrant farm workers in the United States is not a new phenomenon. The presence dates back to the 1850s, when the demand for farming production increased and employment agencies were bringing migrants from several countries to fill the demand because farmers found immigrant laborers more desirable than native-born Americans. The demand for immigrant labor continued. In 1917, the U.S. entered World War I, and as a result, wartime food demands led to an increased need for food production. Yet there was a shortage of agricultural labor workers. This led to the Immigration and Nationality Act of 1917. This act established the legal basis for importation of Mexican laborers, and a total of 73,000 Mexican workers were imported. The influx of migrant farm workers continued throughout the war and well past it. When crop prices plummeted and the need for cheap labor intensified, This was in the from 1917 to 1920s. In the 1930s, a new group of laborers were added. The economic depression of the 1930s and the Dust Bowl displaced American farmers and sharecroppers, forcing them to become migratory workers and join the already existing Mexican and other non-white laborers. The presence of migrant farm workers continued as a result of the Second World War. The war demanded that males be sent to fight in the war, leaving their jobs behind, including those held in the agricultural industry. This resulted in a lack of an agricultural workforce to support this industry. The lack of this workforce motivated U.S. Congress to develop an agreement between the U.S. and Mexico to import Mexican men to work in the U.S. fields. This agreement was named the Bracero Program, and it was signed in August of 1942 and ended in December of 1947. The establishment of these acts formalized the importation of immigrant labor. In 1951, Public Law 78 reestablished the Bracero Program in order to meet expected shortages resulting from the Korean War and required local certification of labor shortages. Braceros at U.S.-Mexico border were waiting to enter into the U.S. Between 1942 and 1947, an estimated 230,173 braceros were accepted into the program. So the process starts. Photos were taken, fingerprints were also taken, physical exams and x-rays were given, vaccinations were given as part of the process, and then they prepared contracts and then of course waited around to work. In 1952, the H-2 program was established. This program was similar to the Bracero program, but this time the law established a provision intended to protect domestic labor. The provision required a certification of a national labor shortage to legally import workers. Although Public Law 78 was terminated in 1964, the importation of migratory workers has not stopped and continues under the H-2 program, which is now known as the H-2 Agricultural Worker Act. This program allows foreign workers to come in legally to perform agricultural labor. In order to begin to meet the healthcare needs of the thousands of migratory workers in the U.S., the Migrant Health Act was enacted in 1962. The Migrant Health Act authorized funds to provide health services for the farm worker population. It allowed for the creation of a small number of migrant health clinics and expansion of existing clinics to include services for farm workers. In 1970, the Migrant Health Act was reauthorized. The National Advisory Council on Migrant Health is mandated and seasonal farm workers are added as eligible populations. In 1983, the Migrant and Seasonal Agricultural Worker Protection Act establishes the right of migrant farm workers and the guidelines labor contractors must follow to respect those rights. The Immigration Reform and Control Act is enacted in 1986, which institutes penalties against employers that employ undocumented immigrants. The Act also grants legal immigration status to 1.1 million formerly undocumented agricultural workers. The IRCA revises the Agricultural Guest Worker Program, which is renamed the H-2A program in 1986. Although it brings in fewer than 100,000 workers annually, the program generates controversy due to the vulnerability of the foreign workers. In 1987, OSHA's field sanitation standard requires agricultural employers to provide toilets, potable water, and hand washing facilities to farm workers in the fields. Slow but significant strides have continued in migrant health with the creation of the Health Center Consolidation Act of 1996. The Health Centers Consolidation Act consolidated community and migrant health center money and allowed for the inclusion of aged and disabled farm workers for eligibility of health services. Health Centers Consolidation Act passes. The Act consolidates migrant health centers, health care for the homeless, health services for residents of public housing, and community health centers into a single Section 330 authority. In 2001, a new initiative was enacted by the Bush presidency. The presidential initiative called for a 5-year expansion plan to strengthen the safety net of community and migrant health centers. The initiative's goal was to double the number of people served and establishment of 1,200 new or satellite access points. Through ARRA, health centers received funds for capital improvement, service expansion, and new access points. President Obama's economic stimulus legislation provides for $2 billion for the CHC program. $500 million is dedicated for increased demand for primary care, dental and oral health, pharmacy, mental health, and substance abuse services. $1.5 billion is allocated for construction and renovation of health center facilities and HIT acquisition. The ACA in 2010, the Patient Protection and Affordable Care Act, ACA, is enacted and signed into law by President Barack Obama on March 23rd of 2010. As part of healthcare reform, the ACA includes a major expansion of health centers, dedicating $9.5 billion to serve 20 million new patients by 2015 and $1.5 billion for capital needs for health centers. It expands coverage under Medicaid to 133% of federal poverty level without categorical eligibility and provides for health insurance premium subsidies for low and modest income Americans through state health insurance exchanges beginning in 2014. Now on to the agricultural industry. Here's a definition of agriculture. The term agriculture means farming in all its branches, including the following: cultivation and tillage of the soil, the production, cultivation, growing, and harvesting of any commodity grown on, in, or as an adjunct to or part of a commodity grown in or on the land, and any practice including preparation and processing for market and delivery to storage or to market or to carriers for transportation to market, performed by a farmer or on a farm, incident to or in conjunction with an activity described in Clause 2. The Health Resources and Services Administration, or HRSA, had provided an operational definition that is a little more narrow. The Uniform Data System, or UDS, until 2009, described agriculture as farming in all its branches, including only those activities that are defined as horticulture. Let's go back here. Agriculture is farming in all its branches, including activities that are not related to horticulture. But in the UDS, it defines agriculture as only horticulture. The UDS excludes workers working in aquaculture and lumbering and etc. as not being eligible for migrant health program services. Definitions for Section 330G of the Public Health Service Act. A migratory agricultural worker, your principal employment is in agriculture. It has been so employed, have been so employed within the last 24 months, establishes a temporary home for the purpose of such employment. A seasonal agricultural worker, principal employment is in agriculture on a seasonal basis, does not migrate. Aged and disabled agricultural worker is an individual who has previously been migratory agricultural worker but who no longer meets the requirement either because of age or disability. There are some industries or tasks that could eventually be excluded once HRSA comes up with an updated definition. Exclusions could involve things that are not directly related to activities done on a farm or in conjunction with a farm, as the legislation talks about. So potentially the people who work transporting animals to the slaughterhouse could be excluded because that person is not doing work on or adjunct to a farm. The slaughterhouse has purchased the animals and the worker is solely involved with the transport to the slaughterhouse, an industry that is not recognized as agriculture. Workers who are taking care of the animals in spectator sports could not be considered a farm worker. Meat processing workers who work for meat wholesalers could be excluded, as meat processing is a different industry. Now, there are some farm workers working in meat processing in organic farms, for instance, who may still qualify as farm workers. Some of the organic farms could be prepared to demographics. This slide depicts the different faces of a farm worker and serves as an introduction to farm worker demographics. Data on farm workers comes from the National Agricultural Workers Survey, or the NAWS, data related to demographics, employment, health characteristics. It's conducted via annual random field survey. Results are not published every year. This data is from the 2012 survey. The migrant and seasonal farm worker population is considered the backbone of the agricultural industry. There are approximately 2.5 to 3 million migrant and seasonal farm workers in the United States. The farm worker population is a young population. 50% of them are between 20 and 34 years old. They're predominantly male. 500,000 children work in the fields. This is a large number of children, and as mentioned in the slide, it is probably an underestimate. Not only dependents of farm workers, but report children working in the fields. A child of age 12 may be able to work in the field with their parents' consent. The farm worker population is primarily a foreign-born population. 71% of foreign-born and reside in the United States. Even though the farm worker population is comprised of a vast majority of ethnicities and cultures, they are predominantly Hispanic. In fact, 78% of the farm worker population is of Hispanic descent. 70% of farm workers reported speaking Spanish as their predominant language. While farm workers work long hours a day, 78% earn below $20,800 and 30% earn less than $10,000 per year. Upon comparison of the average national income, their income results in half to one-third less than an average American. Even though a farm worker may be employed, this does not guarantee such benefits as health insurance. In fact, it is estimated that 68% of farm workers have no health insurance. 41% report not having a health care visit in 2 years, and most have less than 8 years of education. Here is a slide depicting types of crops. So we have fruit, nut, vegetable, horticulture, field, and then there's a miscellaneous percentage as well. Migrant farm workers and their families live in every state. The states that have the greatest amount of farm workers include California, Texas, Washington, and Florida. Classification of farm workers. Again, migratory agricultural worker establishes a temporary abode for purposes of such employment. Seasonal agricultural workers are not migratory, does not need to establish a temporary abode for purposes of such employment. And then, of course, the aged or disabled farm workers applies to individuals who were previously agricultural workers but no longer meet the requirements due to age or disability. Patterns of mobility. So, restricted circuit, following crops in one area, often centered around a home base. Usually a couple of adults from the household move to work, but they come home frequently. Point to point, move away from their home base for extended period of time. They often go back to the same location for multiple years, and often a whole family travels together. Nomadic, they travel to wherever there is work, usually does not know when or to where she or he will move next. Generally foreign-born, young single men working in the United States and sending money home. So migration, home-based states are states where farm workers reside when they are not working in farm labor. Largest home-based states are California, Texas, Washington, and Florida. Upstream states are those states in the northern region of the United States with a high concentration of farm workers. The largest upstream states include North Carolina, Michigan, Colorado, and Indiana. We're seeing more migration in the solo male population. Families are staying behind. Farm worker migration today, there is an increase in the number of H-2A workers. Again, more males are traveling alone, fewer families traveling together, more established in rural communities as seasonal workers. There's less trans-border crossing, and the workers are engaged in other industries during the off-season, construction, meat processing, dairy, and others. Adequate, affordable, and safe farm worker housing has been and continues to be a constant struggle for migrant and seasonal farm workers. The following slide will highlight some of the issues involved with the problem. Adequate, affordable, and safe is difficult to find. Nationally, 58% of farm workers rent housing, 21% live in housing supplied by their employer, and the remaining 21% make other accommodations, including living with friends or relatives, in their cars, makeshift shelters on or by the fields, and also in the camps. Farm workers need decent, affordable housing as they migrate from one community to another. Without their labor, growers cannot maintain current production levels, thus creating food shortages that ultimately affect consumers in the form of higher prices. Hired farm workers, particularly migrants, face barriers to obtaining housing in the local private housing markets. Small rural communities may not have enough rental units available, or they may be unavailable to migrant farm workers because they cannot provide deposits, qualify for credit checks, or make long-term rental commitments. Agricultural employers recognize that the lack of housing is a serious problem, but they face several disincentives to providing housing for migrant farm workers. The need of the farm worker population to find temporary housing has traditionally been met by growers through the establishment of labor camps. However, construction and maintenance of housing is expensive, especially if the housing will only be occupied during a short harvest season. Some employer-provided housing does exist, but ironically, attempts to enforce housing standards have created a trend towards agricultural employers discontinuing the provision of housing. Private housing is not subject to federal regulation. The private housing that is available to migrant workers tends to be substandard and many times expensive. Although some hired farm workers live in well-kept housing, much of the housing available to them is deficient, crowded, and unsanitary. In addition, they often lack safe drinking water, bathing or laundry facilities, and even adequate sanitation. As a result, workers may share a small, grower-provided room with several other people. In the absence of housing, farm workers may be forced to sleep in tents, cars, ditches, or open fields. The migrant labor force is important to the agricultural sector, which in turn is an important part of the overall local economy. It is clear that steps should be taken to help migrant farm workers find solutions to their housing needs. Farm work is not steady. It is dependent on season, weather, and market demands. Farm workers work hours to accommodate the crops, not vice versa, and therefore they're paid by different methods. Some are paid per bushel, per box, per hour, or per day. On a good day, working long hours, a farm worker can earn a good day's pay. But there are times when the workers have to deal with unforeseen factors such as delays in crops, bad weather, breakdown in equipment, and so forth. These workers are not reimbursed for the hours or days lost due to these factors. Many times, this is why entire family members, including children, many who are under the age of 14, may be found working in the field. According to the U.S. Department of Labor, construction is first most dangerous, and farm work is tied with forestry and fishing. Year-round, work is not always possible due to the nature of agriculture, seasons, crop production, and weather. On average, farm workers work 34 and a half weeks of the year in agriculture and 5 weeks doing non-farm work. They are typically employed by the growers or packing firms directly, with a small percentage employed by labor contractors. Pay and benefits vary widely across the country. For direct service providers and health centers, it is important to find out what farm workers are doing in the community in which, when they are not doing farm work. Farm work is not steady, as we mentioned. It is dependent on, again, season, weather, and market demands. So approximately 11% are paid at a piece rate per bushel or per box. 83% are paid by the hour, with an average around the national minimum wage of $7.25 an hour. 6% are paid by other payment methods, including salary, by the day, or combinations of hourly and piece rate. H-2A workers can earn more, with an average between $9 to $10 per hour. On a good day, working long hours, again, the farm worker can earn a good living, but there are times when the workers have to deal with a lot of these unforeseen factors that we mentioned. As far as benefits are concerned, many farm workers do not receive benefits such as overtime pay, sick leave, paid vacations, workers' compensation, retirement plans, or health insurance. Only 22% of farm workers use public assistance programs or need-based services, for example, WIC and food stamps. Many of them may not be eligible, or they do not realize they're eligible, or do not know how to access these services. Agriculture is considered one of the 3 most dangerous occupations in the nation, behind only transportation, warehousing, and constructions for fatalities in 2011. In 2012, 22.8 out of 100,000 farm workers died of work-related injuries, when compared with 3.4 out of 100,000 in the general population. Injuries are due to machinery involved with farm work, the type and nature of the work, such as the heat and the sun, and also exposure to pesticide agents. This displays a picture of occupational and environmental risks that farm workers face daily. The following slides will provide some basic information on the occupational risks of farm work. Many of the occupational injuries that farm workers face are related to specific type of work that they do. Farm work includes, but is not limited to, stooping and picking, carrying, lifting, equipment work, packing, and transport. Repetitive motions and heavy lifting can cause pain, exacerbate arthritis, and other health problems. Other risks relate to the way agricultural work is set up. The practice of piece rate wages encourages people to work longer, harder, and faster without breaks. Beyond the expected physical impact this practice contributed to workers not taking the time to take care of themselves while working. For example, these workers are not going to medical appointments, and there's a lack of management of chronic health conditions. Injuries to farm workers can also be caused by tractors, machines, silo accidents, falls, and there's also crush injuries. Vehicle accidents are a large problem amongst farm workers. Farm workers are often transported to and from work by their crew leaders in unsafe vehicles, which may not have seat belts. They may be overcrowded as well. In addition, because they frequently migrate, the opportunity for accidents on the road is greater for farm workers than the general population. 12% of all non-fatal farm injuries between 1992 and 2005 occurred while working with farm equipment. Farm work often requires stoop labor, climbing, carrying heavy loads, working with the soil, and direct contact with plants. This direct contact with plants puts them at risk for exposure to pesticides and chemical fertilizers that are used in cultivating the plants. Some plants, such as tobacco and strawberries, release chemicals that are toxic to humans or that can cause severe allergic reactions such as contact dermatitis. In addition, there are anecdotal reports of farm workers resorting to irrigation ditches and runoff ponds when safe water is not available for drinking and washing. Pesticides, chemical fertilizers, and organic wastes contaminate such waters. Drinking and bathing in this water exposes farm workers to potentially harmful chemicals and also to waterborne parasites. Farm workers suffer through many injuries and illnesses as a result of being employed in this type of occupation. Those employed in this occupation are at higher risk of death than workers in every industry except mining and construction. Sanitation and hygiene issues include unavailability to safe drinking water, lack of nearby toilets, and lack of nearby hand washing facilities. To address some of these occupational risks, OSHA has put regulations in place that require agricultural employers of 11 or more workers to provide drinking water, hand washing facilities, and toilets for the employees. However, farms with 10 or fewer employees are exempt from these requirements. The intention of this exemption was to avoid placing an undue financial burden on small farms. However, as a result, these very basic amenities are not required by law for many farm workers, regardless of the conditions or hours required of them by their work in the fields. Regulations that are specific to agricultural workers, the Department of Labor, Migrant and Seasonal Agricultural Worker Protection Act. This establishes the rights of farm workers and the guidelines that labor contractors must follow. OSHA, the Field Sanitation Standard, applies in all states and requires availability of potable water and sanitary toilet facilities. And Environmental Protection Agency, the Worker Protection Standard, federal regulation designed to reduce pesticide poisoning by requiring safety training, notification of pesticide applications, use of personal protective equipment, restricted entry intervals after pesticide application, decontamination supplies, and emergency medical assistance. It is important to remember that enforcement is dependent on the size of the farm and the entity in charge of enforcement in that area. Farm workers are excluded from the following labor rights: the right to organize and bargain collectively under the National Labor Relations Act. They are not entitled to overtime pay under the Fair Labor Standards Act, and they are only covered by 7 Occupational Safety and Health Administration standards. This means that farm workers have less protection than most other labor groups and are at greater risk for illegal and unfair treatment, injuries, and unhealthy conditions, scams, and many other risks. This slide serves as an introduction to the coming section on farm workers and their health status. Now that we have looked at history, demographics, and risks, let's take a look at how this impacts overall farm worker health. Although many of the health problems found in the general population, particularly among minorities and the poor, also affect migrant farm workers, the hardships of the life as a farm worker result in unique challenges to the health of these workers, their families, and the healthcare system. In many cases, the frequency or intensity of a health problem is greater within the migrant population than in the population at large. Some health concerns are clearly attributable to the occupational hazards of farm work. The occupational risks associated with agricultural work can lead to health issues. You may encounter some of these injuries or illnesses in patients that you see at your health center. It's important to ask the type of employment to conduct an accurate assessment of the presenting problem. Many occupational injuries are a result of repetitive movements that are involved with picking and packing. Carpal tunnel syndrome, ulnar nerve compression, which are both arm-related injuries. The following are some chronic injuries that farm workers can acquire resulting from stoop labor: back pain or general chronic back pain, spinal stenosis. This is a back disease in which the narrowing of the spaces in the spine or the backbone results in pressure on the spinal cord and or nerve roots. Also lumbar disc disease. This is disease of the lower back, and also exacerbation of arthritis. Farm workers may lack access to clean drinking water and sanitary facilities, including hand washing facilities in the field and at home. OSHA's field sanitation standard requires agricultural employers to provide toilets, potable drinking water, and hand washing facilities in the field. Many farm workers live in employer-provided housing on or near the farm. Farm workers' housing also tends to be overcrowded. There's also housing violations, including rodent infestations, lack of adequate bathrooms and kitchen areas, and exposed wiring. People working in agriculture may have the same rates of chronic disease as other populations. There is not enough research to indicate a higher or lower prevalence. The primary challenge for a farm worker patient is a chronic disease, especially one who migrates, is continuity of care and self-management. Mental health is also a concern among farm workers. In fact, 80% of respondents to the Binational Farm Workers Survey reported needing relief from stress and anxiety. In addition to their high levels of stress brought on by their work and living conditions, farm workers reported high levels of depression, anxiety, substance abuse, and domestic violence. Factors that impact mental health include traveling alone, family separation, and lack of family support. It is known that intact families experience lower rates of smoking, drug use, and risky sexual behaviors. In addition to their high levels of stress brought on by their work and living conditions, farm workers reported high levels of depression, anxiety, substance abuse, and domestic violence as mentioned. Farm workers may be reluctant to talk about mental health issues due to cultural barriers and maybe this stigma attached to mental health issues. Now we'll go into the Migrant Health Program. This slide is a photograph of JFK signing the Migrant Health Act in 1962. This coming section provides information on the Migrant Health Program. The Public Health Service Act 329 was enacted in September of 1962. This act called for the authorization of public health funds for the provision of health services to the farm worker population. It is known as the Migrant Health Act. The Migrant Health Act allowed for the creation of a small number of migrant health clinics. Since then, the number of health services available to the farm workers has increased, as well as the number of farm workers served. Initially, the Migrant Health Center served only farm workers and therefore operated only during the agricultural season. This created a community sentiment of preferential treatment to farm workers within the communities where the Migrant Health Centers were located. Community members expressed dissatisfaction and demanded access to those health centers. In response to this sentiment, the federal government made money available to health centers already receiving migrant dollars to jointly serve the community under Section 330 of the Public Health Services Act. This meant that health centers receiving federal assistance under Sections 329 and 330 were under obligation to provide services to both migratory farm workers and the community as a whole. Although some health centers have done an excellent job in maintaining the focus of serving both populations, others have been overwhelmed and therefore serve a fewer number of migrant farm workers. This problem is further aggravated by the limited resources available to provide outreach, translation, transportation, and other enabling services needed to serve the hard-to-reach migratory farm worker population. In October of 1996, the Health Center Consolidation Act, Public Law 104-299, allowed the consolidation of funding for community health, that's 330E, migrant health, 329G, and homeless health, 340H, and other programs. Under this consolidation, the migrant health money was integrated into community health funding and expanded its reach to recognize the aged and disabled farm workers. Presently, there are approximately 130 nonprofit organizations that receive partial funding to provide services to the migrant seasonal farm worker. Those organizations offer about 500 service access points to the farm worker community. Together, they serve about 650,000 of the 3.5 to 5 million migrant seasonal farm workers annually and have a penetration rate of about 20%. Under this arrangement, the grantee receives partial federal funding from the PHS Section 330E and G to provide services for people in the community and for the migrant and seasonal farm worker population. Although the size and extent of services varies by centers, the majority provide comprehensive care within their networks. It is not uncommon to have one or several centers provide basic insight services and complement the care by referring the client in need of additional services to larger clinics within their network. As a general rule, the larger the budget, the more comprehensive services they can offer. At a minimum, the federal government requires that the following services be provided. Services required: primary care, preventive, emergency, and pharmacy. All current migrant grantees and their satellite sites. It represents a total of 1,964 access points. Now make a note that not all points necessarily represent clinics serving farm workers. Since grantees are identified by the source of 330 funds they receive, that's migrant, homeless, community, public housing, their satellite sites, with the exception of those sites not included in their HRSA scope of service, adopt the same classification whether or not those sites provide services to farm workers. For example, a community migrant health center in Oklahoma has about 14 sites, but farm workers are only served in only 2 of those. Similarly, Community Migrant Health Center in Florida has a total of 43 sites, 9 health centers, and 34 school-based health centers, but farm workers are only seen at 5 of those sites. Approximately 861,120 farm workers were seen at community and migrant health centers across the U.S. With an estimated population of 3 million, this means only approximately 28.7% of the population is accessing the primary care services of the network of community and migrant health centers. There is still a lot of work to do in outreach and enrollment to make sure we are identifying and documenting the population and providing the best access needed by this population. There's a little information about health center funding. Health center budgets range between $500,000 and $25 million. The Bureau provides approximately 28% of the health center's total budget. So for every dollar provided by the Bureau, the health center must raise $3 additional. Enabling services that help to ensure access to the required primary health care services. They facilitate access to comprehensive health and social services. Services include, but are not limited to, case management, services to assist patients gain financial support for health and social services, outreach, transportation, eligibility assistance, patient and community education, coordination of care, and interpretation and translation. The following slides will talk about the problems with barriers to health care and the problems with continuity of care among this population. So I've left a poll question in this webcast for you just to review and discuss and maybe think about which of these barriers most impacts your patient population. Could be that all of these may impact your patient population, their constant mobility, language limitations, their health beliefs, transportation issues, and lack of health insurance. The average migrant farm worker spends approximately 7 to 8 months per year doing seasonal work, 5 weeks doing non-agricultural work, and 4 weeks on the road. They can typically be unemployed for 8 weeks. Mobility and long days often threaten their health and pose a significant barrier to accessing health care. As previously noted, many farm workers have total family incomes below the federal poverty level. 82% of farm worker patients at migrant health centers in 2011 were below the federal poverty line. This puts a farm worker in a predicament of having to choose between paying for health care and meeting their basic essential needs. Many farm workers do not have health insurance, which forces them to seek medical care only when it is absolutely necessary. Preventive care may not be a priority. Because of the limited benefits that farm workers receive, sick leave is rarely an option. So farm workers do not take time off from work to take care of their health care needs for fear of losing their jobs. One of the most commonly reported barriers is language. An estimated 81% of farm workers cited Spanish as their native language, and therefore their inability to speak English fluently or comfortably can pose a great barrier in their health care. Many farm workers have low levels of literacy, even in Spanish. The culture of a farm worker often gets in the way of accessing medical care as well. For example, farm workers often rely on homeopathic remedies handed down from generation to treat ailments, and therefore put off seeking medical care until it is often too late. Farm workers are often unfamiliar with the United States healthcare system and therefore do not seek existing services or have the knowledge to navigate the healthcare system effectively in order to meet their needs. And of course, lack of transportation. Rural areas without a mass transit system can also pose as a barrier to receiving healthcare services. Other barriers are associated with healthcare operations and can be influenced by specific attention to the needs of the population to ensure that services are accessible. So how can we let patients know that we do have translated documents and interpretation services? And are we providing things at the appropriate literacy level in both English and Spanish? How do we provide culturally competent care at all levels of the organization? Are we providing extended hours, Saturday hours, or taking clinics to where they are? Is there more that we can do to provide transportation and access? How do we equip our staff and outreach workers to provide information about accessing the system? How can we learn that home remedies and alternative remedies patients are using to treat what they think they have? Are there ways of addressing that so that this doesn't become a barrier? If you are in a healthcare setting, you may want to discuss some of these barriers and ways that they can be addressed within your organization. Continuity of care is one of the most difficult issues in quality of care for migrant farm workers. The mobility of migrants, even when many return to the same area year after year, makes continuity of care difficult. Geographic relocation may occur several times during the course of a year. The disruption on the chronic disease management of a farm worker often occurs due to the nature of their migration cycle. Proper case management will help to prevent this, as well as prevent many misdiagnoses that may occur, and also the chances that the patients over-medicate. We must make emphasis on self-management of chronic illnesses. It is very important to educate and help farm workers know what they should do to manage their illness and what information and records to take with them when migrating. So here's some service delivery adaptations for special populations. Provide culturally sensitive healthcare services, employ bilingual staff, offer patient education materials in English and in other languages geared to lower literacy levels, also provide increased points of healthcare access, walk-in appointments, evening and weekend hours, mobile health units, also provide appropriate service delivery models, case management, portable medical records and EHR transmission to other community and migrant health centers, lay health promotoras, outreach and enabling services, and also coordination with schools and work sites. So we really thank you for your participation in this webcast of Orientation to Migrant Health. We encourage you to use this information and to further learn about the migrant health community and also, of course, the population that you serve. For any questions, please see this contact information for myself. I can be reached by email, brito@ncfh.org, that's BRITO @ncfh.org, or by phone 512-312-5459. Thank you for joining us for Orientation to